So today our speaker is Dr. Paolo Dominelli, who is a new assistant professor here in the Faculty of Physiology. He did his bachelor's, master's, and PhD in kinesiology at the University of British Columbia, and then also completed a postdoctoral fellowship at the Mayo Clinic. His lab seeks to understand the conductance of oxygen across multiple systems, including pulmonary, cardiac, and muscle systems. So looking forward to your talk, and thanks for speaking today.
Sure, thank you. Great, thanks for the invite today. So excited to give my talk fairly broad, talk about generally what I study and then some specifics on a few different studies that we've been working on and then going forward. So I kind of named it asking questions and building tools. That's kind of what I think what we do in my lab. Oftentimes there's not really things to do, but we want to answer our questions. So it's just so you kind of have to hodgepodge things together. That's part of the fun of it. So I'll skip through this quick. Thanks for the introduction, but it's the same. So yeah, I'm from Vancouver. I went to UBC for all my graduate degrees. There's our little building there at the far end of campus, right next to all the sports fields. It is as dumpy as it looks. They no longer actually have anything we do in there. They have a nice new building just on the corner there next to the ice rink. So after that, I was actually in Kelowna for a little bit, UBC Okanagan there, just to do a few studies before my postdoc. I was at Rochester, Minnesota. Always looks this beautiful and bright and sunny in Rochester. Just 365 days out of the year. Nobody's been to Rochester. That's why there's no laughs. It does not look like this. It's very cold and much colder than Calgary. But Mayo Clinic was a great place to be at for a year and a bit. And then I was actually an assistant professor at the University of Waterloo for 5 years before I came here to Calgary earlier this summer. So to start off with, a big question that we ask in my lab is, how do smaller airways in females influence the integrative exercise response? So I'm kind of setting this up. This is the big question that we ask, and there's of course a lot of sub-questions now beyond that. So this is a schematic of part of what I'm going to talk about. I'm not going to go through every aspect of this here. But this, again, I think highlights kind of what we like to look at, starting with some anatomical and morphological differences, functional differences, and then some of these unknowns, some of which we've kind of addressed recently. Well, before I get into any talk about sex differences, what I want to kind of make clear is a few things here. Is when we talk about sex differences, sometimes people might get confused with a term we actually refer to as sexual dimorphism. And I won't actually be talking anything about sexual dimorphism today. Okay, so if we look down at the panels down at the bottom here, sexual dimorphism is when you have two completely separate groups. Okay, males, females, and there's really no overlap between them. So a classic example would be something like gonads. Sex differences, this is overlapping phenotypes between them. Okay, so you can pick whatever phenotype that you want. So you look at it, things we're familiar with, height, hormone levels, hemoglobin concentration. Okay, on average, one sex might be greater or lesser than the other, but there's considerable amount of overlap. Okay, just think of height. On average, males are typically taller, but there's huge overlap between the groups. So everything I'll be talking about today is actually sex differences, not sex dimorphism. Okay, the next thing is when we talk about sex or sex and gender. So I'll be referring to sex today, which is a set of biological attributes, primarily associated with physical and physiological features. So this is kind of the definition that CIHR uses. I won't necessarily be talking about gender today, although some of the work we've done looks at gender specifically, but this is socially constructed roles, behaviors, and expressions. So this is different from biological sex. You might think of, well, why do we care about sex differences in the pulmonary system? Well, it wasn't that long ago that people didn't think that females could do any kind of endurance exercise. Okay, so this, most people might be familiar with the case of Catherine Switzer, who's the first female to register and run in the Boston Marathon, or first marathon, they often kind of say, and that was done in 1967. But for a Canadian spin, only a couple weeks after this, actually Maureen Mancuso is the only female Canadian marathon record holder ever. Okay, so she did this time of 3:15:24, and actually did it 2 weeks after Catherine Switzer's run in Boston. Catherine's actually knew Maureen and actually ran in the same run, but was quite beat up after her first marathon only a few weeks ago. And she ran the last mile in 6 minutes flat. And like Catherine Switzer was told she shouldn't run and that it would hurt her. It would hurt her beyond ways that she could repair. Okay, we obviously know this is not at all true anymore. And a nice sexual snippet from one of the articles at the end says, race physicians checked her heart right away, noting how much less windage she seemed compared to her older male counterparts. Okay. So we of course know that such feats are more than capable. And you only have to look to a few weeks ago, where the women's world marathon record was actually broken by a considerable amount. It's now down to 2:09:56. This was literally just done a couple days ago in Chicago. So to put this into perspective, I may have missed one person, but I believe there are like 2 Canadian males who have ever run faster than this ever. And that was only done a few years ago. Okay, so this is an incredible accomplishment. Before I get into differences between males and females in terms of pulmonary system, I think it's also really important to highlight that there's actually more similarities than there are differences. This is from a review paper we did a few years ago. And on the left-hand panel, we're actually showing all the things that essentially are completely unchanged between males and females. So your typical breathing patterns, how much you breathe during exercise, the temporal associations, those essentially don't change. Those are identical between males and females. It's really only when you start diving into a lot of the mechanics, and that's what I'm going to be focusing on today, that you actually do start to see these differences between males and females. Okay, so if we start with, well, what is causing these differences that I keep hinting at? Well, we believe that it's all due to airway size differences. So how you can measure airway sizes is you can actually recreate the airway tree that we have here on the right-hand side. So this is a computer tomography reconstruction. Every one of the airways that has the asterisks in it is significantly smaller in females. You may say, well, that's not all that surprising. I told you earlier, on average, females are shorter than males, so it would make sense that they have smaller airways. The second set of asterisks indicates the ones where if you've matched for lung size, the airways are still smaller in females. When you match for lung size, you essentially take out height, because height very well scales with lung size. So this is independent of height and independent of lung size. Females still have smaller airways than males. Okay, now you may look at this and say, well, there seems to be a bit of a problem here. These are older individuals and they're former smokers. Is this just the pathology coming out? So it was a really good aspect that we wanted to address. So a few years after that, we actually looked at a very large group, large age range, 19 to 86, and these were never smokers. These are people who had no history of any kind of smoking. They were actually cleared for every single pulmonary disease that I knew about. We actually had a few physicians work on this too and screen them for diseases that I'd never even heard about before. So these are completely healthy individuals. We have airway luminal area on the y-axis, and then there's several different branches of the airways. So for example, trachea is your trachea, your main one here, right main bronchi, et cetera, et cetera. What you can see is that female airways are about 20 to 30% smaller than males. And again, that may not sound like a huge deal, but airway resistance is related to the size of the airway to the 4th power. Okay, so any very subtle changes in airway diameter or luminal area have tremendous impacts on airway resistance. So recently there's been a lot of discussions about reproducibility of science and whether things are truly reproducible or just kind of one-off spurious findings. So I think it's actually important to show that this is a very reproducible finding. So this was a review that we looked at a few years ago, actually during COVID, so we're allowed to do much health. And we took all the studies that we could find that actually looked at airway luminal area in males and females. And so each of the A, B, C, D, these are different studies. There's not many done on this. There's R1, previous one. Notice this one is from individuals living in Cyprus, quite far away. It has nothing to do with our current one. This one's in the northeastern US. The way you can see is it's remarkable how consistent this is. Number one, just the absolute values are very similar across multiple studies, but also the difference between males and females, with the males being the filled in circles. And even since that we've published this work, some colleagues of mine, we've actually taken advantage of what's called a CanFull database, which is a Canada-wide random sampling that did actually include some chest CTs in it. So this was individuals about 40 years old, and this is the healthy subset. And you can see they, again, fall basically exactly on all the other ones. And after that too, there was a study, this was actually looking at genetics of COPD, but again, it has some chest CTs in it. And so this was across 20 centers across the US, random sample, with about 10 or 20,000 people in total. And they didn't actually provide the values because that wasn't the specifics of their study, but they do have a line there saying that airway lumen size quantified at chest CT were smaller in women than men after accounting for height and lung size. Okay, so this is now, we're on our 6th study, large samples, completely different populations that have no overlap at all, and it's almost identical results every time. So we're quite confident that this is a real effect. Okay. So you might ask, well, yeah, these are all adults, 18 or 19 above. When do these differences occur? Are these innate? In other words, are these born with them, or do they develop later on? Okay, so this was something we tried to answer by, again, obtaining some CT images in individuals all the way right after they were born, all the way up to 18. So this is cross-sectional, this is not longitudinal. That's why there's a bit of jumping up and down with these. And again, we have airway area. It's just for the trachea, right main bronchus, and left main bronchus. So hopefully we can appreciate is very young individuals, absolutely no difference in airway size. They're completely on top of each other. And it's only at around puberty that you get this increase in the males. And the males start to increase greater than the females. And again, you may say, well, is this just height related? If you correct it for height, the differences are attenuated, but they're still present. Okay, so this is just now, we call it an airway index. It's just taking your luminal area divided by height. Again, you can see the youngest individuals essentially completely overlapping. And then when you get in and around puberty, the males start to increase out of proportion to the females. Okay, so this seems to be something to do with at or around puberty is causing that increase in airway growth disproportionately in males. Okay. So if we say, all right, so the airways are significantly smaller in females, how does that actually impact the integrated response to exercise? So one of the things that we'll look at is something referred to as exercise-induced arterial hypoxemia. So if we think of this, at max exercise, okay, so this is just individuals, this is their different VO2 max in the x-axis. In the y-axis, we have their arterial oxygen tension. And if you look at any textbook, it says it should be between 90 and 100 millimeters of mercury at end exercise. That is the normal response. And if you look at this and you ignore all but the fittest males here, kind of down here, that is actually generally the response. It sits around 90 to 100. Might be a little lower here in Calgary because there's a bit of elevation. But what you do see though, is you see some females are relatively untrained at this lowering of their arterial oxygen saturation pressures. And so they're developing this gas exchange impairment. So really the question is this real or is this just a function of small data sets? Okay, so we tried to investigate this a number of years ago. What we had is a large group of females. We had about 40, which doesn't maybe sound large, but you'll see in a second why these are relatively hard to do studies. We had them exercise on a treadmill, was our kind of cross-sectional one, and then we did an experimental intervention, which I'll show next to you here. Okay, so if you're wondering what that bag is hanging next to the person, so that is a pressurized saline bag, and that's going into the arterial catheter. How you get arterial oxygen tension is you have to sample arterial blood during exercise. Okay, so this isn't a trivial technique, so this is what it looks like putting in the arterial catheter. There's a physician inserting it. Not one of the subjects, that's a different person that we did it in. And here's what it looks like before it gets all taped up. So the catheter goes into the artery, and you're able to serially sample blood. So I actually put a picture of the blood here. It's a little hard to see just because of the lighting, but it's not as bright as you would typically see arterial blood. Okay, normally arterial blood is quite bright red. It's highly oxygenated. That's a little duskier because that's an individual who's hypoxemic. So that was blood taken near the end of exercise. So what did we find? Well, we found that females do seem to exhibit slightly more exercise-induced arterial hypoxemia. If you take that regression line, it kind of falls below the males. And interestingly, you get this group of females who are relatively untrained and develop it more than males. And so the question is, well, why is this? Why do females seem to develop exercise-induced arterial hypoxemia? So the second part of the study was actually trying to experimentally tease why that is. And so we postulated that might have to do with mechanical ventilatory constraints. So when you exercise, you are not able to breathe indefinitely. Okay, there is a limit to how much you can ventilate. Okay, and one way you can quantify that is to have someone do a maximal expiratory flow volume. So what that is, you have the person take a big breath in, they fill up their lungs completely, and exhale as hard and as fast as possible. So this solid red line is that right there. Okay. You cannot breathe outside of that. I'll explain that dotted one in a second. So when you look at these ones in here, you see it's all falling within that curve. So in other words, that means that person has an ability to increase their ventilation, but they're not mechanically constrained. So what we want to do to actually experimentally test that is if you give someone heliox gas to breathe, heliox is less dense than nitrogen, that max flow volume actually gets a little bigger. You can actually breathe more. Well, what happens if you give it to a person who already has the ability to breathe more? Right, you can see this person is not overlapping. When we look down at the ventilation, and not much actually happens. So why would you? Right, you already have the ability to breathe more. I've let you breathe even more on top of that. Why would you just breathe more? There's no real benefit to doing that. Okay, so nothing much happens in these subset of people. But if you look at a different subset, okay, notice these individuals were up against their mechanical limit to breathe. We then allowed them to increase their ventilation, and they did. So they took advantage of that relieving of their mechanical constraints and were allowed to increase their ventilation during exercise. What does that look like in terms of blood gases? So the colors are the same here. So the non-flow limited individuals, gave them room air, heliox, no change in ventilation, so no change in arterial blood gases, versus the ones that were able to increase their ventilation. Arterial oxygen significantly goes up, put them back on room air, it goes back down. Okay, so we can relieve those constraints, they can breathe more, they can better oxygenate their blood. Okay, so this doesn't sound like a huge amount, visually it probably doesn't look like that. Okay? But in terms of a high-end athlete, 1.5% improvement in your saturation, that can be anywhere from a 4 to 5% improvement in your VO2 max. That will also attenuate your fatigue by a similar amount. Okay, so if you're talking about a high individual here, this is a huge amount of an increase. And there's unfortunately not a whole lot you can do about it. And so what we've seen previously is females do exhibit more mechanical constraints. And so this was our rationale of why there may be some increased exercise-induced arterial hypoxemia in females. The important note is it doesn't completely abolish it. You notice it doesn't go back to rest. It just attenuates a little bit of it. Okay, so it's not the main cause of the hypoxemia. We'll move on to one of the other things. Okay, so what does the mechanical and metabolic cost of breathing compare between males and females? Okay, so you might say, well, how do you actually call or measure the metabolic cost of breathing? It's skeletal muscles, right, your diaphragm and others, but you can't really attach force sensors to them. So to get around that is we actually take a unique little advantage of anatomy in that your esophagus, you can see here in a chest CT cross section, is actually basically right next to your pleural space. It's your pleural space is what surrounds your lungs. And ultimately, we actually want to measure your pleural pressure. Okay, but to measure pleural pressure, you have to pull a hole in your chest wall, put a catheter in there. It's really not going to lead to good things. That's going to give you no pneumothorax. Okay, but if we put a catheter in your esophagus, because your esophagus is flaccid, if you're not swallowing, the pressure in your pleura gets directly transferred to your esophagus. Okay, so you can actually measure your pleural pressure by measuring your esophageal pressure. Okay, so we do this by putting an esophageal balloon, that's that thing right there, up the person's nose, they take sips of water, they swallow it down, it sits right in your esophagus. That's what it looks like in the back of someone's mouth. So this allows you now to quantify the amount of work that your respiratory muscles are doing. Okay, so when you do that, and you look at males and females, you have here is on the x-axis volume, y-axis is our esophageal pressure, which I just explained. Here, this is just a single male and female, just for illustrative purposes. They're both breathing about 70 liters a minute, so decent level of exercise, but not maximal. And hopefully what's pretty obvious here is the loop by the females is a lot bigger than the males. Bigger loop, more work. Okay, they have to generate more pressure to move the same volume of air. Why is that? Smaller airways. Okay. So if you now look at it on bigger group aspects, so now this is just your total work of breathing. Okay, so this is how much work you need to respirate with the different ventilations. Okay. Both males and females show this kind of exponential increase as ventilation gets higher. I just haven't put the stat symbol in here to be cleaner with it, but above about 60 liters per minute is when females start to have a higher work of breathing. And that is when, if you actually model the airflow dynamics, that's when airflow turns turbulent in female airways. So it's that turbulent airflow that's causing higher resistance, which is causing this higher work of breathing. Okay, so you might say again, well, who cares if your respiratory muscles have to work a little bit harder, right? It's not that big of a deal. Well, we now want to know, well, what's the metabolic cost of that hypertrophy? Okay, so we told you about the mechanical cost, but what does that actually cost you in terms of metabolics? So again, this led us to having to kind of build some tools to figure this out. Because how do you measure how much oxygen uptake does your respiratory muscles consume? You can't put catheters in those arteries and veins just through their anatomical location. So we have to find another way to measure the oxygen uptake. So what we did with this one is we devised kind of a series of systems where we made our own gas, secure tanks, filled really big Douglas bags, okay, had the person breathe it while they were sitting on the bike at rest, and they mimicked their exercise ventilation. Okay, so a few days before, we had them do a maximal test. They can get their flow volume loops, how much flow they're generating in the mouth, and their pressure volume loops that's derived from their esophagus. Okay. And then we gave them real-time feedback, and they could sit there for 5 minutes straight and breathe like they were during exercise. So they're staring at the screen and just breathing in and out, in and out. We're preventing them from passing out by changing the different gases. We're able to quite precisely measure how much oxygen has been consumed. And if we assume everything else is inactive at this point, they're just sitting at rest on the bike, then the O2 that's increased, that's the oxygen consumption of respiratory muscles. So this is what it looks like in practice. We called it the world's worst video game because you basically literally sit there and just trace a line over and over and over and over again. If you think this is not difficult, try breathing like you do at max exercise for even 30 seconds. It's very difficult. Okay, so we made them do it for 5 minutes to really get a representative estimate of the VO2. Okay, so what did that look like? Then we have our ventilation on our x-axis, VO2, the respiratory muscle on the y-axis. Then we see both groups going up. And you see this kind of exponential rise near the end. Hopefully people might recognize this should mirror the work of breathing. Work of the VO2 should be linear related. Indeed they work. If you really look at this though, you might go, well, who really cares? If I drew a line at the top, well, that's about the same. It's about 450 mils in the females, and about 450 mils in the males. So is it really that different of a metabolic cost? The metabolic cost is the same. I would agree with you in absolute terms. What about the relative terms? Okay. Well, if you now compare it at VO2 max, okay, so the highest ventilation that the person has achieved, and now express the y-axis as the oxygen cost of the respiratory muscles as a fraction of total VO2. Said another way, how much of your VO2 is dedicated to your respiratory muscles? Okay, in males, it's about 10%. In females, it's about 15%. Okay, so females are dedicating about 5% more of their VO2 towards their respiratory muscles. Why does that matter? Well, we only have to look back to our Fick equation, which describes how you actually calculate VO2, which is the product of cardiac output and AVO2 difference. You ignore the AVO2 difference, which is generally not all that different in males and females at max exercise. That tells us that females have to dedicate a greater fraction of their cardiac output to their respiratory muscles. More is going to the respiratory muscles, less is going to those active locomotor muscles. Okay, so that's what the kind of implication of this is insinuating. Last thing I want to highlight on this one, look at the overlap. yes, on average, females are higher. But there's a number of females that are below the average of the males and vice versa. Okay, there's a huge overlap between these groups. It is not a dimorphism where the two groups are completely separate. So to switch gears for the last little bit here. And so I kind of teased it as saying, well, now the respiratory muscles, now I'm starting to talk about cardiac output. So how much do the heart and the respiratory system interact? Are they completely separate? Do we need to consider them together? So this is another question that we typically ask in the lab, and that is, how do the respiratory and cardiovascular system interact during exercise? Well, how will we test this? Well, you need to manipulate one and then you measure the other. So we typically like to manipulate the respiratory system. How do we do that? We actually built a custom ventilator which will breathe for the individuals during exercise. This is just a little schematic of it. Basically compressed air, increasing the pressure at the mouth. Explain in a few slides how that makes it easier to breathe. So this is kind of the engineering schematic. This is what it looks like in practice. For anybody that may recognize that person, that's Dr. Jerry Dempsey riding the bike. He's kind of a founding father, as it were, of respiratory physiology during exercise. So he wasn't a study subject, but he wanted to try it out and was quite pleased with how it's built. And here's us with our shitting in our mouth because it's actually working for once. So yeah, it's homemade because it was homemade, but it does the job. So this is what it looks like. So on the right hand side, we have no assist. So this is just spontaneous breathing. Bottom panel, we have our soft gel pressures. Remember, that's with the catheter in the person's esophagus. This is a surrogate of how much work they're doing. And so when you take a breath in, your soft gel pressure goes negative. You breathe out, it goes up towards zero. You're breathing in, out, in, and out. So this is your mouth pressure. So let's just measure it at your mouth. And so this mimics flow. So when you take a breath in, pressure goes negative, right? You're drawing air in, you breathe out, pressure goes positive. Okay, so this is our normal situation. But what happens when you turn the ventilator on? Okay, so I've highlighted just two inspirations here, just for illustrative purposes. What you notice now is during inspiration, mouth pressure is not negative anymore. Now it's positive. It's positive because the ventilator is now applying positive pressure at the mouth. And if you have positive pressure at the mouth, that means your respiratory muscles have to generate less pressure. Okay, all you're doing is breathing by a pressure gradient. So what you can see at the bottom here is these esophageal pressures get a lot smaller and they get narrower. So your respiratory muscles are not having to work as hard. But we can take away that normally associated work of breathing, or in other words, manipulate the respiratory system. Now we can see how that affects your cardiovascular system. Okay, so a little bit ago I said, well, if you're dedicating more of your VO2 to your respiratory muscles, less is going to your leg. That's just not me saying that, that's a real finding. Okay, if you manipulate your respiratory muscle work, you can change how much blood flow goes to your leg. Okay, that was done by a study in the late 90s. What they weren't able to show though is, well, where does the blood go and where does it come from? So in other words, they could just show that it went up to the leg if you reduce the work of breathing, or it goes down to the leg if you increase it, but they had no idea where that blood was coming from. Did cardiac output changing? Was vascular conductance changing? Didn't really have a good sense of that. So to address this, what we wanted to look at was, we asked, well, are there bidirectional changes in respiratory and lymph blood flow when we alter respiratory muscle work? So we had to measure both of them at the same time. And so what we did that is took advantage of a technique actually used in many hospitals, which is infusing a green dye. I'll show an up close picture here in a second. You can kind of see the physician infusing it there. And what we have is on the quadriceps here, those are optodes that are measuring the oxygen spectrum, basically how much light is refracting on this. And that will change depending on how much of that dye is in the bloodstream. Okay, you can do some math and you can calculate then the blood flow to that limb. So there's the dye, that's what it looks like going in. It quite literally is green dye that goes in. So then those optodes can detect that amount of essentially green in your blood. And now we can quantify the blood flow. What's not seen on the other side is he has some of those similar optodes on his respiratory muscles. And so we're able to quantify respiratory and locomotor muscles simultaneously. Okay, so what does it look like? X-axis, we have our work of breathing. So anything above 100, we've made it harder to breathe. Below 100, we've Ventilators made it easier. The y-axis is our sternocleidomastoid blood flow. So this is our respiratory muscle. As you increase the work of the respiratory muscles, as expected, blood flow goes up. If you decrease it, blood flow goes down. For those who might question this, if you remove those two people, the relationship is still significant and still present. Okay, so these are included, we call it for our academic honesty, but these do not actually change the relationship. We now look at blood flow to the legs, vastus lateralis, versus the work of breathing. We see the opposite relationship. When you increase the work of breathing, blood flow is going away from your legs. If you decrease the work of breathing, blood flow is going up to your legs. Okay, so there's this bi-directional competitive relationship between the respiratory muscles and your locomotor muscles, which this would insinuate your locomotor muscles are actually taking priority. So they're getting perfused with the blood flow at the expense of your working locomotor muscles. So the next question that we asked was, well, how does that actually happen? How do you get these changes in blood flow across different muscle groups? And specifically, we questioned, well, are these respiratory-induced changes sympathetically mediated? So again, we needed to be able to measure sympathetic changes. How do you measure sympathetic changes? We need to tap into the sympathetic nervous system. What we did in this study is a little hard to see here, but after that person's kind of crease their elbow right there, is a very tiny needle, an MSNA needle, a tungsten electrode, both the size of an acupuncture needle, that's actually placed through the skin and sits actually inside your sympathetic nerve. So this is a live recording of your sympathetic nervous system. Okay, so I am in no way able to do this. This was done with a collaborator from Japan, who's basically the only person in the world who can successfully do this. So this is a really fun study to have him come out and do it. There's our ventilator you can see in the background there. So on our y-axis, we have work of breathing. X-axis is just duration of exercise. Started exercising, they're breathing more, work of breathing goes up. Turn on the ventilator, work of breathing goes down. Turn the ventilator back off, work of breathing goes up. And this is the expected response. We're able to manipulate respiratory muscle. At the same time, this is what the sympathetic response looks like. Turn the ventilator on, sympathetic nervous activity goes down. You turn it off, it goes back up. Okay, so now we have some very direct evidence that this is indeed a sympathetically mediated redistribution of blood flow. We're able to directly show that it's this changes in sympathetics that's lining up with the changes in the liver. Okay, so the next one we kind of asked more recently here is, well, how does changing respiratory pressures, how does that affect your heart? Okay, your heart and your lungs are in the same thoracic cavity. So if we're changing one's pressures, does that impact the other one? So again, our same kind of intervention here is you imagine soft geo pressure. That's when our ventilators turned off, or sorry, turned on. Here's when it's turned off. See much higher pressures. Top panel, we have work of breathing. So I've shown you many times, we can lower the work of breathing. More novel one here is with your stroke volume. By changing the pressures in and around your heart, you can actually impact your cardiac function. Specifically, you actually will interfere with both the filling of your heart and this ejection of the blood out of your heart. Okay, so you're actually impacting both diastolic and systolic function of this. I think this kind of sums it up quite nicely. Of the thing is when you alter your intrathoracic pressure, changing the work of breathing, you will actually acutely change stroke volume and cardiac output. Now, this isn't just kind of our own way to manipulate this. This would be not much different if you said that person had lung disease and that was a healthy person. Okay, so we're manipulating in healthy people, but this effectively mirrors what you see in various pathological conditions. Okay, so the last one we're going to talk about is we're going to flip back to male-female differences because we like to kind of come full circle here and talk about female differences, heart-lung interactions, and now kind of looking at them together. So a bit of a background is that if you infuse norepinephrine into a forearm of a male, their blood flow to that forearm will go down. This is nothing new. Okay? This is just showing you sympathetic control of the vasculature. On the y-axis is just forearm vascular conductance. all we're doing is showing it's going down. There are two different plots here. One of them is when we have a control condition. The other is when you block a specific type of receptors called beta receptors. Beta receptors are found in your vascular tissue. What this tells you is really beta receptors don't do anything in young males. Look at what it looks like in young females. You look at the control condition, which is filled in circles. You can give higher doses of norepinephrine infused into the brachial artery. It does absolutely nothing to the female's vascular conductance. Females are essentially insensitive to sympathetically mediated vasoconstriction. This is actually the reason why hypertension is very uncommon in young females. But as you get older and you lose some of these beta receptors, it becomes more common. How do we experimentally tease that out? Block beta receptors. Now the relationship looks like males. The females have a beta receptor mediated offset of sympathetic vasoconstriction. Okay. What this all means in the big picture is males and females actually regulate blood pressure and blood flow differently. The end goal is the same, but they get it through different mechanisms. Okay, specifically, females are reliant on beta receptors and males are not. So what we kind of question with that is, this was all done at rest. It's just a person lying there. We question, does this actually happen during exercise? In other words, excuse me, are beta receptors in females responsible for greater increases in exercise blood flow in females? So what we had, just finished a study recently, is our subjects lying down and they progressively increase their leg extension exercise until they couldn't do it anymore. So it's the custom ergometer under here, and they're just kicking their leg out, measuring blood flow via ultrasound here. And what we have down at the bottom here is under one of the conditions, one was a control. On the other day, we blocked all the beta receptors. And so we did this by infusing a very high dose of the drug propranolol, which is a non-selective beta antagonist. So this blocks all the beta receptors in your body. And the dose is, it won't be much, I'm sure, most people. The typical clinical dose is 1 milligram they would give someone in the hospital, and then they say you give another milligram, and then at max you give 3. We were giving people about 30 or 40 milligrams of propranolol, so extremely high dose. In young people, it doesn't actually do a whole lot. I can attest as one of the subjects, other than afterwards, if you walked up a flight of stairs, you'd be very out of breath. You didn't actually notice a whole lot with the complete bladed blockade. To our surprise, though, it didn't do a whole lot. On the y-axis here, we have normalized leg blood flow. So this is normalized per kilogram of muscle tissue. Here's the control, the propranolol. Don't even need to tell you which are male and female. Those are right on top of each other. Okay. So there's an intensity effect. Yeah, blood flow went up with exercise intensity. There's a propranolol effect, a relatively mild one. If you really squint, you can kind of see it's a little bit lower on propranolol, but there was no sex effect and there's absolutely no interaction effect. So those differences that we see at rest don't seem to translate into exercise. Interesting, what did translate though is the changes in vascular tone persisted. So on this y-axis, we now have change in femoral artery diameter. What you can see in the males is the males don't really dilate their femoral artery in response to exercise. The propranolol doesn't do a whole lot, versus females show a much greater vasodilation with exercise, and propranolol attenuates that dilation. Okay, so interestingly, we have a change in the actual vascular control, but no end-up change in the actual blood flow at the end of the day. Okay. So that ends it. The one thing I wanted to end with, because I always like to kind of end and make people think a little bit. So, you know, we like to ask big, broad questions, and a lot of times those questions don't have answers. So one thing that we've been interested in recently, poll the audience here at the end is, why do you breathe more with exercise? So to kind of get people thinking, I'm now opening it to the audience. We all hopefully exercise. You all have experienced that you breathe more. Why did you breathe more in your exercise? Yep.
Because when you're exercising, there's like muscular demand goes up, and then you need to synthesize ATP and all that, and you also need to offset the carbon dioxide buildup for acid-base balance.
Great, so I completely agree with you. If you correlate ventilation and VCO2, it's perfectly related. What sensed that VCO2 though? So I agree, they're linear related, but that means something had to sense that VCO2 in those metabolites. Nope. Blood gases don't change with exercise, especially acutely when you breathe more. So what sensed that? Any other suggestions of why we breathe more with exercise? Someone might say it's, well, it's the locomotor muscles are moving and those type 3-4 afferents are telling your brain. Yeah, that's true. They do modulate it. You can block those and you still breathe more with exercise. You can take a decorticated cat, you can essentially remove the brain from the equation and you still breathe more with exercise. Okay, so one of the things we're kind of interested in, by no means am I going to answer this, but people have been trying to answer this for well over 100 years and haven't come up with a solid answer. We're kind of interested, how do your chemosensors become sensitized with exercise? So this is from one study, measuring your sensitivity just sitting on a chair. You just sit on a bike, the sensitivity goes up. You do unloaded cycling, the sensitivity went up even more. But yet it had no impact on how hard you exercised. So again, the whole idea of metabolites, VCO2, seems to correlate well, but are you saying you're not producing more of those things near threshold as you are unloaded cycling? Of course not. But that sensitivity hasn't changed. Right, so this is kind of a, hopefully get people to think of, well, basic questions of why do we breathe more? Why does blood flow go to exercising muscles? We do not actually have a perfectly clear answer to those questions. And these are kind of the things that we like to try to put some pieces together for them. So with that, thanks to all my students and our funding sponsors. Any questions?
What kind of changes do you see when you're doing the assisted breathing and the partial pressure that you get in the lungs? Does that affect the rate in which you uptake oxygen or?
So like the alveolar partial pressures?
Yeah.
To date, we have not put an arterial line in while we've done a PAT study. That'll be happening in the new year. Previous work doesn't actually show it changes all that much. Your gas exchange efficiencies, most of these studies we do near max exercise, so your AA gradient is pretty wide. It'll go up or down a few millimeters of mercury. Your ventilation goes up. It doesn't have a, what I'll call it, a systematic change amongst people. Most likely because even though we're probably improving a bit of your alveolar PO2, it's probably doing something to your vasculature in your lungs because all that pressure is probably actually compressing a little bit, which in itself is probably worse than gas exchange impairment. To do that would require additional kind of methods to parse those things out, which we've not kind of done at that point yet. So it's a good question. We don't see any consistent gas exchange effects on it.
I'm curious what the efficiency of breathing is, because they say that, say, for cycling, positive work is about 25% efficiency. Is it the same for breathing?
It's worse. It's under 10% generally. Now, the problem with that estimate is that's a very crude estimate, right? When you measure the work of breathing with esophageal catheter, that's just the changes in pleural pressure. That doesn't necessarily account for changes in diaphragmatic pressure. We can measure that too. We put another catheter in your stomach. But that's hard to kind of reconcile both of them. What it also isn't really able to add in is you do a lot of work stabilizing your chest wall when you breathe that aren't necessarily reflected in pleural pressure, plus your respiratory muscles also have postural effects. So when we do our estimate, it's about 6, 7, 8% for efficiency. But that is certainly not a true reflection of the whole system's efficiency, because there surely is other things we're just not able to quantify those for. But when we look at it, it's probably not ever different between our groups, right? We're generally young, healthy individuals. So if you were to look at, say, a very obese person, we know that changes your respiratory mechanics. That weight basically on your chest distorts your chest wall, and you have to do additional work. So their efficiency would actually go down. But again, it's very difficult to quantify. So it's less, I'm confident saying it's probably less than other locomotor muscles, but I couldn't give you like a perfect answer how much less it is.
And can you, can people do exercises to make their work of breathing easier, you know, like increasing the diameter of the vessels or anything?
So there's no way that I'm aware of that you can change your airway tone. Other than, of course, if you take a beta-adrenergic Ventolin, right, what you take with asthma. So that's why, for example, Ventolin is banned by WADA in the Olympics. That's also why you will see a lot of athletes have asthma, because then they're allowed to take Ventolin to some degree. Now, whether that actually improves performance, though, is not clear. They just ban it out of abundance of caution. In the general sense, no. Some people have tried what's called respiratory muscle training, so you can breathe against resistance. That will strengthen your respiratory muscles, and that will absolutely work. You can generate more pressure, you're a little bit more fatigue resistant. The problem is that has yet to actually show into any performance outcomes, because your mechanical ability to breathe is not determined on your respiratory muscles, it's determined by your largely your airway anatomy. And I'm unaware of anybody that's ever been able to show that short of pharmaceutical manipulations. And you can certainly make it worse, right? You see a person who's having an asthma attack, airways constrict, they're harder to breathe. I'm unaware of a way other than, say, Ventolin or another beta receptor adrenergic that you could improve your airway size.
Well, how about stretching? Because stretching can affect the lines of, you know, your muscle tendons. So how about for your?
Absolutely. So when you, we've actually done this. We've done studies where you put a bronchoscope in and you can actually see the person's airways in real time. We were, of course, the first subjects for this. When you take a breath in, your airways tether open, and they do that naturally. That is, we talked to evolutionary biologists, that's actually some people think the reason why we sigh and yawn is that increase in lung volume actually kind of tethers open your airways and it's good for them. But when you are normally exercising, you breathe up to very high lung volumes. So you're already increasing the tone every time you breathe in, and then it decreases a little bit when you breathe out. So you're just cyclically doing that all day, all the time. You might say, okay, well, a high trained athlete, they're exercising to a high degree, maybe they're getting more of that. Nobody's ever shown that the pulmonary system of trained people is functionally different than an untrained person. It's the one organ system that doesn't seem to adapt to physical training. So you can take some of the VO2 max in the 80s or 90s. It will look no different, their airways and lungs, as somebody who's a VO2 max in their 30s. And that's cross-sectional, and people have done longitudinal studies where they've trained people, followed lifelong kind of athletes for 10, 15 years, and they're no different than controls. If anything, there's some evidence that they get a little worse because the airways actually get dried out because of the high velocities. You see that actually in the cross-country skiers of all people. Because the high velocities with cold, dry air, basically.
Well, I'm thinking more in terms of an analog of the regular stretching we do. So, you know, athletes will have somebody who massages them and then they'll do these stretches, right? Some of them active or some of them are passive plus active. So what if you took athletes and you know, basically blew into their lungs, and maybe they also do some active assist. So there's a procedure, a little bit like the active stretching that athletes do. And then it sounds like with your devices, you could make an estimate, I guess, from the slope of your PV curves.
Yep.
It kind of gives you an idea of the stiffness.
Yep, absolutely.
So I'm just wondering if that might have a possibility.
So I'm unaware that anybody's done that. Yeah, your lungs, like other tissue, they get stiffer the more stretched out they get. Probably the closest analog is, so people who have cystic fibrosis, is one of them. Muscular dystrophy is another one. Well, they actually will do exactly what you say. So in Duchenne's muscular dystrophy, typically their muscles aren't sufficient to inflate their lungs all the time. They breathe at very low lung volumes. So it's actually quite beneficial to them. They do it 2 or 3 times a day. Somebody will inflate a bag, as you said, inflate their lungs, and their compliance will actually get better. So we've done a study to actually compare that with healthy people. And when you do that, that inflation acutely in healthy people, there's no change in compliance. You do that in someone with Duchenne's muscular dystrophy, their compliance gets better. And likely that's clearing phlegm and just that stretching, but the thought is a healthy person is still cyclically doing that all the time. So again, I don't know of any way that's done it, say, to a higher degree for, say, like 8 weeks or something like that. I'm unaware of that. That may be it, but I can certainly say acutely, it doesn't seem to change airway tethering risk.
Do you know if there are differences between the mechanical properties of the airways and the capillaries between males and females?
In health, not really. I can tell you in COPD, the pathology manifests differently in males and females, both in the airways and in the small blood vessels. Generally, in terms of the airway, like the parenchyma, the elasticity is not different in males and females. If you just look at the pressure volume relationship with compliance, it's basically on top of each other. There's a lot of variability amongst people, but there's nothing systematically different. The airways are smaller, but they don't appear to be morphologically different, right? They're a very conserved kind of organ other than that. In terms of the capillaries, it's quite difficult, as you can imagine, to kind of image the pulmonary capillaries. I can tell you pulmonary capillary blood volume expands with exercise in both males and females. The absolute volume is lower in females just because the lungs are smaller. I'm unaware of anything other than a size effect. Everything you see is just, okay, there's less capillaries because the lungs are smaller, or they don't expand as much because they're just, the volume is less. But if you scale out volume, they're basically function the same.
Okay, so they're not compensating for their mechanical properties to the small size.
Not enough. So the lungs are, we typically say the lungs are actually overbuilt. So when you say compensate, what do they need to compensate for? Because, and other than highly trained individuals, the lungs are not limiting exercise performance. So it's, you know, you can almost argue, well, why would you compensate for something that's not needed? That's probably then when we start to see these differences in these diseases, because now they are at the kind of limits of the lungs. And so maybe that's where these kind of things start to split. And that is, you know, a huge area of research, not for me, but other people looking at COPD, for example, and how, unfortunately, for example, the same number of pack years, females seem to get worse COPD than males. But they don't actually get as many symptomatic exacerbations as males. So again, maybe that's a bit of a compensation. I don't know. It's fairly burgeoning research, we'll say, fairly new.
What about fiber types in the respiratory muscles?
As far as I know, they're no different from males and females. Again, I know of only one study that's ever taken fibers from a living person. You can imagine that's the one, especially I mean, the diaphragm's your main respiratory muscle, you can't access that. That one was in, I think they had a few controls and they took some intercostal muscles. Generally, the diaphragm, for example, is about 50-50 in terms of slow twitch and more oxidative ones. We don't really have a good idea of what the rest of the respiratory muscles are, just because almost everything is done from cadavers. There's some issues with that. So.
You mentioned that the female airflow is more turbulent. Where is that coming from?
The smaller diameter airways. So if you take for the same ventilation, so to move the same amount of air, if the airways are smaller, then they're going to be more likely to start developing turbulence in those airways just due to the velocity changes.
You know, we did some work on ski jumping and their turbulence was positive. I mean, it helped.
Yep.
Bigger distances, couldn't it be something like that here?
I don't think so. So the turbulence in this case increases the resistance to flow, right? Like you want laminar flow in terms of flow through a pipe. I guess that's probably, my guess is the turbulence probably aids in some degree of lifting. That's essentially kind of, to a very crude degree, what you're doing in an airplane, right? You're changing the flow properties over a wing, and that provides you some degree of lift. In a tube, though, you want all the molecules to go in a nice uniform direction. In turbulence or spinning going in a different direction. So you have to have a greater pressure change to achieve that same flow. And that greater pressure change is what's causing the higher motion breathing. And you can get turbulence for other reasons, right? If you branch an airway more, you'll create more turbulence. And so that's not something I even talked about. We don't think there's any differences in the branching, but between people, the branching of your airways is incredibly heterogeneous. Some people have more sharp branches, some people are more kind of acute angles, and depending on even just your main bronchi, if I go all the way back here. This is just a representative figure. Colleagues of mine have actually started really kind of looking into this. Some people's bronchi come out almost like flat, like that, for whatever reason. And they have way higher work and more turbulence because the air, of course, has to come and make 90-degree turns. Versus some people, it's much more kind of acute angle, it's more sharp and it goes down. And that's a lot easier to ventilate. And that does not appear to differ based on sex, but for unknown reasons, it's very different across people. And every branch actually has some degree of angle of branching, essentially.
I actually have a question. So does this fact that it is smaller, the airways are smaller in females than males, have only acute effects, or does it have long-term effects as well?
We don't know about long-term effects. Again, this kind of then questions long-term effects in a healthy person or long-term effects in terms of disease. We're probably at the forefront of trying to figure out if these kind of underlying differences cause differences in disease manifestation. Because it would make sense, right? If you start with smaller airways and then you have an airway disease, you're kind of already at a more limited point. Again, I come back to in a healthy person, your lungs are overbuilt, right? In the absence of disease, not many people are dying of respiratory failure. Chronic heart failure or something else, right? We kind of almost get a number of like your lungs have about 150 to 180% capacity. Right? You have more than you need to do it, and they're rarely what limits you. So in a perfectly young, healthy person, they're not limiting it. In an older, healthy person, they're still not really limiting much. So I think this is really more of a, for a long-term thing, a disease-specific kind of direction that we have to go in, rather than a otherwise healthy older person.
And then for exercise-induced asthma, is that more prevalent in females because of this, or is it pretty similar across males and females?
Changes depending on pre or post-pubescent people. Asthma is somehow, and this is right out of kind of the leading people do it, both the most overdiagnosed and underdiagnosed disease. So it's overdiagnosed because most people do not get a complete assessment if they have a breathing issue. You go to a family doctor and you say, you know, I'm exercising, I have trouble breathing. Most of the time, that is actually just an acute kind of either allergic reaction or infection or recovering from, say, a lung infection. You don't actually have reactive airways in asthma. But to cover your bases, you're typically would be prescribed a short-term inhaler, long-term inhaler, and then antibiotics, because it basically covers all the bases for it. The number of people that will come into our lab and say, oh, I had asthma. And now we actually go, okay, just come do the test and we'll see. 9 times out of 10, they don't have asthma. They're completely unreactive to an actual test. On the other hand, then, you have to distinguish between asthma and exercise-induced bronchoconstriction, which are actually, again, most people would lump them together, but they're 2 different diseases. Right? Bronchoconstriction is typically cold, dry air, and you have an acute reduction in your airways, and it's harder to breathe, and then it'll basically alleviate itself spontaneously. Asthma is much more of something to trigger it. It can be environmental, it can be a number of things, and you get kind of an acute clamping, basically your airways will get a lot smaller. That is an allergic inflammatory response versus the bronchoconstriction isn't necessarily an inflammatory mediated response. So they're actually different, and that's why, again, I think it's both overdiagnosed and actually underdiagnosed.
And for people of the same height and weight, do you think that females that have less muscle mass?
Yeah, like peripheral blood muscle mass?
Yeah,
Or,
let's say, yeah.
that's a better question for Mark, I
And
think.
what I'm thinking about is that maybe they do not need as much oxygen And their airways are small because the metal mass at the end, when they're walking and the stuff, it's smaller, so they don't need as much oxygen.
Absolutely, so that's why we typically like to scale when we show things. I typically like to have it as both an absolute measure over an absolute measure, and also then a relative measure, So that's exactly why you have this one, for example, the oxygen cost of breathing. Right, if you look at it in terms of absolute, yeah, of course, the females, it's lower because their VO2 is higher, right? You don't need to breathe as much. These people out here breathing 200 liters a minute, their VO2 at that point is 5.5 liters per minute. That would be an extremely exceptional female who could get up to a VO2 that high. So, yeah, you'd absolutely say, well, this is just scale. That's where this one kind of comes in. So we're at now a relative measure, so you're at max. And this is now saying, as a fraction of that max, it's higher. So yeah, you're absolutely right. Most things, when you eliminate size effect or muscle mass, it attenuates, but a lot of them we find are still present. They're just attenuated down. But you're absolutely correct. It does scale for size. There's no reason why you would have a higher VO2 in your respiratory muscles if you are breathing down here at 50, right? A very unfit person. And this is why, another reason why we typically like to test highly trained people. Because as I mentioned, right, your airways and your lungs don't respond to training. Your heart, your muscles do. So your ability to breathe is basically fixed once you stop growing. It actually only unfortunately goes down throughout your entire life. But your VO2 can go up and down, your muscle mass can go up and down. Yeah, there's a general, age-related decline, but you can change that quite a lot. So where we see these kind of pulmonary limitations are highly trained individuals or well-trained older individuals. Well-trained older individuals have lost some of that pulmonary function, but because they're so well-trained, they've maintained a lot more muscle mass, cardiac adaptations compared to, say, somebody who's never really trained, and their muscle mass and cardiac adaptations have also declined with age. So those are the kind of the interesting ones to look at: is older people, healthy older people, and highly trained athletes.
So for your studies here, when you talked about exercise, induced hypoxia, and also for those studies, like what is the medium that you use to like test these athletes? Were they in an indoor environment or outdoor environments, and how does the environment play a role in the differences, like talk about male and female experiencing exercise induced arterial like hypoxemia or whatever? Does the weather, let's say like colder weather or warmer weather, does that influence any of these changes here?
So the weather will impact to a degree your arterial oxygen tension. That is because of the atmospheric pressure. So for example, I said textbook answer is 90 to 100. Textbook answer in Calgary is actually 85 to 90 because we're at higher altitude. And that higher altitude, lower barometric pressure, which causes all these things to be a little lower. So in theory, right, if you go from, say, even at sea level, you're literally right at sea level, and you go a very high pressure day compared to a very low pressure day, your arterial oxygen tension will be a little different. We're talking a couple millimeters of mercury. That's just kind of a generic thing, not necessarily related to the hypoxemia. All these studies, as far as I know, have been done in a lab. I mean, they have an arterial catheter in there tied to this high pressure bag. It's generally a physician. There's one and there's another off the street, kind of following them around. I'm unaware of anybody doing this per se in the field. The only one that I really know of is in one of the Everest studies. They actually took arterial blood gases at the balcony, which was at 26,000 feet. They weren't acutely exercising, but they were just exercising. That is one of the few arterial blood gases I'd say in the field that I'm aware of that they've taken. So maybe everything's done in the lab though.
Pertaining to this study though, would you say there is any difference between males and females adapting to like differences in weather or like altitude, or they say the scale is about the same?
Weather, I don't know. I mean, there's so many things that would go into that. In terms of altitude, males and females, I mean, you go to altitude, you perform worse. Everybody performs worse, right? It's just one of those generic things that happens with life. I'm unaware of anything showing females are worse off than males. The problem with that is, again, now we're talking chamber studies or terrestrial altitude. When you look at terrestrial altitude, generally not all that different. These are highly motivated, generally good climbers, who are going to be motivated by other factors, and that's probably actually what makes them perform worse. Right? You typically, one of the reasons you actually see highly trained, highly motivated people actually go worse at altitude because they're kind of stupid. They go too hard, they get sick, and then they have to take breaks. Versus the person who goes up much more modestly isn't going to be affected as much. There's been few cross-sectional studies looking at people who develop this sign in the lab and then exposing them to high altitude. The hypoxemia does not seem to predict any function at high altitude. So, but those again are cross-sectional. They do one thing in the lab and they do another thing out in the field. They're not doing them at the same time. But it doesn't seem to directly translate it.
And
I have
then,
one online.
Okay.
Robert, do you want to go ahead?
Yeah, can you hear me?
I can, yep.
Yeah, I'm just calling from Melbourne, Australia. The American Thoracic Society dismisses one of the measurements of small airway disorder, which is maximum mid-expiratory flow. I think it's also called FEF 25 to 75%, because they say it's too hard to measure. But in looking at your presentation, you're sort of saying that small airways are an important issue for women. When respiratory physicians quote the American Thoracic Society and dismiss the measurements of small airway disorder, I'm just wondering what your opinion is of those measurements of small airways that are used in a, say a lung function test.
Yeah, so it's a really good question. So interestingly, actually, the differences in airways, if I go back to this, it's not actually the small airways that are different. It's the large conducting airways that are significantly smaller females. So typically we see that in terms of trachea, and then generally up to about the 4th or 5th generation is where we stop seeing differences. Now, the problem is, do those differences not exist at the 6th, 7th, and beyond generation, or are they so small because now we're talking, of course, airways in the 1 to 2 millimeter range and much smaller? Are we just not? Are current measurement techniques not sensitive to detect such a small change? I don't know that. The other aspect is 80% of your area resistance is these large conducting airways. So, on one hand, I would agree, right? The small airways in a young, healthy person really aren't that impactful in terms of flow properties, right? Most of the resistance is the large airways. They shouldn't really have been impacted by much, and especially if we talk about males and females, it's all these upper airways that are actually doing a lot of it. So to a degree, I would agree with that. It then becomes the question of, well, why are you assessing their pulmonary function if they don't have any manifestation of something? So I guess I almost need to know a little bit more of why they were saying they'd be assessing the mid flows. We typically report the mid flows. I can say on an absolute terms, males are bigger, but in percent predicted, they're identical, the mid flows compared to males and females.
Right. There are forms of asthma where the large airways are not reacting. FEV1, forced vital capacity, and things look fairly normal and not reactive. But there's an argument, I gather, that the small airways, 1, 2 millimeter, are where the asthma problem can be. But the way I saw it before looking at what you're doing, asthma in small airways, and if women have more of them, might be a bigger problem, doesn't seem to get accepted. Asthma seems to be viewed by the respiratory physicians, in my understanding, as a large airway problem. But there are some people who have no large airway symptoms, but they do have small airway symptoms. And therefore, if you're a woman, then maybe you have, more susceptible to that type of asthma. Or is is it not asthma? What do you think?
Yeah, no, that's a really good point, and I think that brings down to, so, you know, I'm not a clinician, so I'll start by saying that, a lot of that clinician speak, I'll say, I actually get from my brother, who is a respirologist. Yeah, and we like the lungs in the family, and, you know, it's an interesting one, because if I were to fault the physicians a little bit, right, they just care about a numerical outcome, right? Person comes in, you give them the methicillin challenge, their FEV1 goes down. And they don't really care if it's a small or large airway. So I think they almost, my kind of critique of them is they just revert to what's an easier explanation rather than getting into the physiological difference, which I would argue is a lot more interesting. I do know a group out of the States, they do a quite cool technique. They have people inhale hyperpolarized helium. You can actually visualize the airway tree quite nicely, because normally you can't when you MRI, because it's just all air instead of water. And when they do that in asthmatics, the level of constriction is not homogeneous throughout the lung. It's actually quite remarkable. You know, you can see it, and it just won't go to some areas, and it's completely random where it goes. So I think it's actually even more to that. You might have somebody who has, you know, large airway constriction, and then that's causing, you know, peripheral gas exchange issues, but doesn't actually have it on another part of their lung, and it's almost more of a small airway disease. So I think there's probably a lot more than we appreciate with the variability amongst people in terms of where the asthma is occurring. And I agree with you, it can have probably two different phenotypes, and then how it's actually occurring in the lungs. But again, the physician definer goes back to, well, do they really care? No, they just need to treat it. The treatment ends up being the same to them, which is maybe not the best scientific argument, but seems to work from a clinical management point of view.
Yeah, well, terrific. Thank you. And I'm really enjoyed your presentation.
Thank you.
Then we had a question and then we'll keep going.
The final question. Now you started your job now here. And let's assume it's 30 years later.
Yeah.
And you give a talk again to us about what you have done and how that is relevant for your mindset. What is that?
Yeah, so things that I'm really interested in, I mean, if I can, in 30 years, I can provide good answers as to why our peripheral chemosensors change with exercise, how that changes ventilation, that and explaining how the heart and the lungs interact between males and females. So in other words, we've done bits and bobs of these kind of mechanical interaction things, but to basically make a nice picture like we've done in terms of sex differences in airways, that would be something I would kind of be proud of after 30 years to say, here's now male-female heart-lung interactions, how those all kind of go out through different organs, but that of course ending at say muscle fatigue. How does that impact the aging? How does that now impact the clinical disease? So kind of taking that basic big question and spreading it out over many different populations and what that means in the end. Come back in 30 years.
All right, on that note, let's thank Dr. Dominelli for his